Hello, my name is Kathleen Koth, and I will be talking to you today about intellectual developmental disorder. I started working with children with developmental disabilities as the daughter of a special education teacher, thinking that I could never be that patient. But when I got a job working with developmental disabilities, and what at the time was the emerging world of autism spectrum disorders, I discovered a real love for working with children who were nonverbal. I still love working with them, and it takes all of my attention to pick up the subtle changes in their behavior. While these cases can be difficult, the families are amazing, and it is an honor to be on the journey with them. I have no disclosures. The objectives of today's lecture is to review the DSM-5 criteria for intellectual disability, also known as intellectual developmental disorder, to discuss the evaluation of psychiatric comorbidities in individuals with intellectual developmental disorder, and to understand current evidence-based treatments for psychiatric conditions in those with intellectual disability. So a little bit of historical understanding before we start. Feeble-minded comes from the Latin fibelis, meaning to be lamented. It indicated someone who was in need of care or intervention, not necessarily cognitive in nature. The older proper medical terms are feeble-minded, imbecile, moron, and idiot. The Association for Medical Officers of American Institutions for Idiotic and Feeble-Minded Persons was founded in 1876. It was not until 1961 that the term mental retardation officially was adopted as a term referring to significant sub-average intellectual functioning existing concurrently with deficits in adaptive behavior and manifesting during the developmental period. In 2013, with the DSM-5, there was a paradigm shift in the definition to not just include cognitive and adaptive functioning, but the definition was further characterized by deficits in general mental abilities such as reasoning, problem-solving, planning, abstract thinking, judgment, academic learning, and learning from experience. This was a shift from just what they could do in testing to what they could do in daily life. Why would we diagnose IDD, and why is it important to include it in your problem list when working with individuals who meet this criteria? It helps to communicate with others by conveying that there are deficits. Other physicians who read that will have a framework with which to work with this patient. Schools and agencies can communicate with the patient and help communicate the patient's needs to each other. It can also help qualify the patient for supportive services that will help them make the most of their environments. As I noted before, there was a paradigm shift between the previous DSMs and the 5th edition, which moved intellectual developmental disability as a mental disorder rather than a separate axis. There are no longer any IQ criteria or cutoffs as there were in the past for the different levels of dysfunction. The criteria are now based on adaptive domains, which we will look into in more detail in a minute. All children should be screened for intellectual abilities and cognition during their regular pediatric well checks at 9, 12, 18, 24, and 30 months of age. The American Academy of Pediatrics has several screening tools in their toolkits, including Bright Futures. A pediatrician can then refer to a qualified neuropsychologist or psychological tester for testing for cognitive and adaptive functioning. Children may come to attention later when the demands of their environment exceed their abilities, especially in mild IDD. When positive, testing for etiology should start in the pediatrician's office with careful family and developmental history, a full physical examination, and medical workup. That medical workup may include genetic testing, especially if a cause of ID is not otherwise determined, including chromosomal microarray and Fragile X for both boys and girls, and metabolic testing, including seroamino acids and urine organic acids. With the paradigm shift away from IQ level of functioning, a child psychiatrist and many other qualified clinicians can make the diagnosis in their office based on the function and criteria. In a perfect setting with a multidisciplinary team, the patient should be tested by a neuropsychologist or testing psychologist for IQ levels and other functional tests to help determine both the child's deficits, but also their areas of strength, as points to focus on for future growth. Let's look a little bit closer at the DSM-5 diagnosis for intellectual developmental disorder. Criteria A focuses on deficits in intellectual functioning, including reasoning, problem solving, planning, abstract thinking, judgment, and academic learning, as well as learning from experience. This can be confirmed by both clinical assessment and individualized standardized testing. Criteria B looks at deficits in adaptive functioning that result in a failure to meet developmental and socio-cultural standards for personal independence and social responsibility in the 3 domains that we'll talk about in a minute. Criteria C is that the onset of these issues happens during the developmental period. But understand that if they are mild, they may come out when demands exceed the child's capacities. So this may not be evident until school age or maybe even later in some more mild cases. The severity of IQ is now conceptualized by these 3 domains and no longer by IQ score. The first domain is conceptual or academic and has to do with those things that involve classroom learning in school, such as reading, writing, math, and the acquisition of practical knowledge. The social domain is behavior that's determined by the degree in which it can be understood and processed based on the intellectual ability. Mature friendships are based off of a complex set of skills that's actually learned and is available to use, and so affects the children with intellectual disability. The practical domain is the ability to use intelligence for everyday tasks in life, such as completing ADLs, to budgeting for household responsibilities and employment. Now we'll look at each of the severity levels a little bit more closely. In mild intellectual disability, in the conceptual domain, this may not present itself during the preschool years, but may become evident during elementary school when they show difficulties in learning involving reading, writing, math, or other learning concepts such as time and money. As adults, this can be seen as impairments in abstract thinking, executive functioning, short-term memory, and using academic skills in their overall functioning. Adults with mild ID may be seen as having more concrete approach to problem solving and lacking a deeper understanding of the tasks at hand. In the social domain, individuals may appear to have more immature social interactions than their same age peers. They have more concrete language and conversation. Their relationships may be a bit more basic due to the difficulty in regulating emotion and behaving in a socially appropriate manner for their chronologic age. Individuals may demonstrate a limited understanding of social situations and actually be more gullible or at risk of being manipulated by others due to this. In the practical domain, most of the time ADLs may be able to be completed at an appropriate level for their age, but they may need some help with complex tasks. In their living skills, they may need support in complex skills such as grocery shopping, transportation, organizing home or child care. Their recreational skills can often be at an age-appropriate level and require only some support. Employment is usually at jobs that do not emphasize overall cognitive skills. And their healthcare and legal decisions may require some support, but they may be able to give a lot of input to these decisions. As we move to a moderate severity, they require more support and prolonged time in learning new skills. They have more concrete approaches overall to life. In the conceptual domain, usually becomes evident in preschool, such as their language and the pre-academic skills, like learning alphabets and numbers, may be affected. During the school age, they progress slower and have a more limiting understanding than their peers in reading, writing, and math. Time and money are first and second grade concepts that are actually quite abstract and may really be a good marker of difficulty for those with moderate IDD. Adults have an overall academic skills in the elementary school range, including time and concepts of money. In the social domain, there's a marked difference between persons with moderate IDD and the same age peers. Language is the primary tool of communication, but it's much less complex than their same age peers. Relationships with family and friends can be strong, but not on the level of their chronologic age expectations. They do develop romantic relationships, and they can be achieved at a much more basic level. They may not perceive social cues accurately because of a lack of abstract concept understanding. Social judgments and decisions are made are very limited and often require guidance. In the practical domain, ADLs may be able to be completed independently, but require prolonged teaching and learning times. Often they're learned in a very rote way in which they're unable to deviate from that routine. They can participate in living skills, but with ongoing support, such as grocery shopping and budgeting. Their recreation can be developed, again, over those extended periods of learning time. Employment can be independent if the job requires very limited concepts and communication skills, or if those skills are taught over a very extended period of time. Maladaptive behaviors can be a problem and can cause significant social impairment in a minority of people with moderate IDD. In the severe level of IDD, patients require substantial support from their caretakers in all tasks. Conceptually, they are limited in their attainment of basic academic concepts. Extensive support is needed if they are able to obtain any useful or meaningful way of using those concepts. For example, I have a patient whose understanding of money is to take a bill, has no idea what denomination of that bill it is, and that is exchanged for one item. So no understanding, they know that money has to be exchanged for an item, but that's the level of understanding that they have. In a social domain, they're very limited in their vocabulary and grammar, and it really sets them apart from their peers. Language is primarily used for communication, not really expression or explanation. And while relationships with others are a source for pleasure, it's really at a very basic level without any abstract concepts. Practically, they require support for all ADLs, including bathing, dressing, elimination, and meals. They usually require supervision at all times and cannot make decisions regarding their well-being of themselves or others. They may be able to participate in some sort of employment with a very long-term teaching of skills and constant supervision. Maladaptive behaviors, including self-injury, are an issue in a significant minority. Profound severity requires substantial support for all tasks. In the conceptual domain, they're very concrete in their basic understanding of academics, mostly symbols such as matching or sorting. They also a lot of times have co-occurring motor or sensory impairments that really impact the conceptual domain. Socially, they use very basic language skills for communication only, sometimes single or two-word phrases as well as gestures. They lack explanations for most of their basic needs. And therefore, they're most comfortable usually with family and friends who understand their ability to interact and their means of communication. From a practical standpoint, they're completely dependent for all ADLs and living skills, such as meals and shelter. Their daytime activities may be enjoying a group for listening music, water play, or different social activities. If there is employment or activity, it may be around sorting or other simple tasks, such as maybe vacuuming or watering the plants. So let's talk about an example of how you could start to understand the use of the diagnosis of IDD. For example, a 14-year-old Hispanic male named Joseph comes to your office, and per mom, he has some learning issues. She doesn't have any more information than that. So how could you go about finding out exactly what she means by that? One of the best ways for a school-age child is to ask for a copy of the IEP. The individual education plan is something that the school has to help guide them in their education. It's a federally mandated document, and while they differ between districts and states, there are federal guidelines in what they obtain. During training, I highly suggest you read every IEP that you can get your hands on in order to get more comfortable reading them quickly and understanding what they have in them. So you get an IEP from mom and the plan from the school, and you discover that he attends school in the special education classroom for academics, but attends art, music, gym, and lunch with his same age peers. In academics, they're working on a reading comprehension level around the 4th grade. And in math, they're working on basic multiplication tables, so around the 3rd grade level. He is actually able to get to his classes in the high school alone after being taught by an aide over the last month in how to navigate the hallways and get from one classroom to another. So, as you do with all children, next you spend some time with Joseph, and you get to know him a little bit better in your office. You notice that he socially engages with you well and really enjoys talking to you. When you ask him more complex questions, he gives you pretty concrete answers. He doesn't read your social cues very well, and you feel like you're talking to about a 3rd grader. He does have friends, and he enjoys playing with play dates that his mom and dad arrange for him, or playing on the playground with children who are much younger than his age. When you talk to mom about how Joseph is able to take care of himself at home, you note that he's independent for his ADLs, but his parents have to check and make sure they're done. Like, he doesn't do a great job brushing his teeth, and they still need to check that daily. The parents can leave him home for brief periods of time while they run across the store to get some eggs quickly. But each time they leave, they have him practice calling their cell phone and remind him again what to do in case of a fire, like running to the neighbor's house. They are starting to try to teach him to use the microwave. But the last time he tried to cook a hot dog, he put in 10 minutes instead of 1 minute. It caught fire, and he wasn't able to notice that, nor did he stop the microwave when smoke filled the house. So they're still working very hard on that skill and seeing if he can do some basic food preparation using the microwave. I'm going to ask some questions that you can pause this if you wish to take some time to answer. So does Joseph have a specific learning disorder, as mom kind of insinuated at the beginning, or is there a different diagnosis? And what diagnosis would you give? Why would it help to give a diagnosis to Joseph? And how would you plan for his future? So Joseph has a diagnosis of mild intellectual developmental disorder, looking at those 3 domains. If you need to stop and pause here to go back and look at those domains, please do so. Why would it help to give that diagnosis? It would help all of his caregivers to help better conceptualize what Joseph is able to do and not do through his different life skills. And how would you plan for this patient's future? Joseph, at this age of 14, will likely need assistance in the future from various agencies, schools, and it's at this time we need to start putting those steps into place to plan for his future so that he is able to do as much as he can and have as independent a future, but have those supports in place. So we're going to move on a little bit to the etiology of IDD. And most of the time when we talk about etiology of IDD, we talk about the timing of it. So prenatal, we talk about genetic and chromosomal malformations and growth errors and formation errors in utero. Teratogens and toxins introduced in the fetal developmental period. These can be anything from prescribed medications, environmental toxins, to substance abuse. We look at perinatal causes, including delivery complications and infections upon delivery. And in the postnatal time period, we look at any medical conditions or early infections, trauma to the brain itself, as well as environmental influences of early abuse or neglect and toxins. There may be multiple causes that work together and can be characterized in different fashions to fully explain the possible etiologies. But ultimately, 30 to 50% of the cases have an unknown etiology. Intellectual developmental disorder is a lifelong condition that will affect everything that the individual does. However, it is different for every individual, and the course of the disability can be different for each. Their lives are dynamic and changing, and so too is how it will affect that life. If there's a known etiology, that may give you some direction, but it may not as well. The amount of intervention and how that individual makes use of them will go a long way into determining the overall outcome. But so many factors are individual, personality, perseverance, family systems, and all the things that we're used to looking at as child psychiatrists, and are similar to other parts of development. So in many ways, the things that we look at every day as child psychiatrists will help in assessing a child with disabilities. When families come to psychiatry, they're often presenting with complaints of behavior issues. You will assess how you normally would a child and adolescent in keeping a few key factors in mind, that they have less tools to cope with stress so that small changes can result in big issues. Intellectually, they have less understanding of themselves and the environment. They have less understanding of complex events, both from the fact that they don't understand abstract concepts, but also their lack of ability to use social cues in that understanding. Just as with younger children, it may be helpful to gain knowledge of how they understand the event and not actually what happened. They have a less executive functioning and logic to make sense of those events. This often needs to be provided for them in a more developmentally appropriate fashion. Because they have less executive functioning skills, they can't adequately respond to events or plan those responses. Providing external explanation and scaffolding their responses can be helpful. Getting others' attention and letting others know that they're uncomfortable or something is wrong is a form of communication, but can look like a behavior. They may lack the expressive language skills to express their emotions when things are difficult, or lack the receptive skills to understand simple directions when they're upset. Think about when you're upset, how difficult it is to understand directions, or even come up with the right word that you're meaning to. When they already have communication issues, this can become even worse when they're upset. So one of the most important things to look at is supportive planning for children with IDD, because it's a lifelong diagnosis. Using strength-based learning and intervention can maximize their gains in life. Making sure that they have IEPs in place are very, very important. Social interventions can maximize their functioning and make the most of what they do. Use the neuropsychological testing that you've received to identify the individual strengths and weaknesses of an individual with IDD and help them shape how those interventions can play out. For instance, a child who has problems with verbal processing may do really poorly with the correction system in the school of them counting down numbers as he gets in trouble. But changing that to a visual field that may use colored cards as they get in trouble can help eliminate those behavior problems by having that child understand better what the consequences are. Include this data from in the IEP that help to play on the strengths of the child versus their weaknesses can really help. Using interventions to instruct others, including the peers and teachers and individuals in the community, can really help how the patient interacts and is helpful. But as with all mental health issues in child psychiatry, treatment planning is the key. Using the neuropsychological testing to identify the individual's strengths and weaknesses can help that individual with IDD shape the intervention and play on those strengths. For instance, a person with better visual memory and intellect and intelligence than verbal may use visual strategies such as colored cards placed on their desk as a reinforcement rather than a verbal indication that they've not done well. Including these changes from the data gathered in the IEP is important so that everyone who works with a child is aware of these strengths and weaknesses. Using these interventions throughout their day, so that at school and at home, also help to reinforce and keep their environments more predictable for them. Letting others who know them and may come in contact with them in a crisis, such as other teachers, the police department, or neighbors in the community, can really help know what works for the patient. Emphasize all their strengths. For an individual who loves to socialize, have them deliver coffee to all the teachers as their job during the day, not stuff envelopes in an office by themselves. Or vice versa. Helping use those strengths will really help to engage the person and have them be successful. Making sure the individual has all their medical issues met is also critical. From bowel regimens to constipation to ear infections well treated, it's incredibly important that all of those needs are met as well. And finally, therapeutic, behavioral, and psychiatric medications are being used. They can help the individual reach their fullest potential. Screening for co-occurring psychiatric disorders is something that needs to be done upon every visit with the child psychiatrist, because people who have IDD are 2.5 to 4 times more likely to have co-occurring psychiatric disorders than children without. All psychiatric diagnoses can be found in children with IDD. They can be related to the etiology of IDD, such as Alzheimer's syndrome occurring more oftenly in Down's syndrome, in children who have velocardiofacial syndrome or 22q deletion, have a higher risk of developing schizophrenia than the general population. Children with premature birth can have a higher incidence of both IDD and ADHD. And postnatal neglect can be associated both with IDD as well as other behavioral disturbances. The fact that all psychiatric diagnoses can be found in individuals with IDD, you still need to use a developmental approach in learning that you've learned throughout your CAP training to keep in mind what the expectations are for a person in this age range. What would be the emotional functioning expectation for an older teenager who's actually functioning at a 7 or 8-year-old developmental range? To help with that diagnosis, use an instrument that's developed for people with IDD in order to obtain more accurate results. There are several out there. The Developmental Behavioral Checklist shares a structure with the CBCL that many of you are familiar with. And there are several versions, including the caregiver, the teacher, the adult, and a short version. The Knowing Your Child Behavior Rating Form checklist is available for ages 3 to 16 for both caregiver and teacher. It's a 76-question evaluation, so it's a longer one. And the Reese scales for children's dual diagnosis is from 4 to 21, with both caregiver and teacher versions, and takes about 10 minutes to answer. As an example, here's one that looks very familiar looks very similar to the CBCL or the Vanderbilt that you may use in clinic. The psychiatrist needs to make sure that these psychosocial treatments are in place for these co-occurring disorders. They need to make sure that behavioral therapies are in place and that positive reinforcement strategies are being implemented. The professionals are in place to analyze what the meaning of these behaviors are and best formulate the strategies to decrease their frequencies. Individual therapy can be very, very helpful in patients with IDD. There are readily available books to help clinicians do cognitive behavioral therapy or PCIT with individuals who have IDD. But any therapy can be modified for someone with moderate or mild IDD to help with individual therapy. Family therapy can be very helpful, both to support the family around having an individual with IDD as a member, and helping to maintain those behavior strategies that have been taught to the family, and just help the family overall assist this individual to become the best that they can. Pharmacotherapy should only be considered as part of a comprehensive treatment plan. Consider all medical comorbidities as the first step. I cannot emphasize that enough. Make sure that they don't have constipation, pain, infection, or something else wrong before assuming that a behavior is just a behavior. Guidelines for all psychiatric co-occurring disorders should be followed in persons with IDD. If they have ADHD, then treat ADHD. If they have anxiety disorder, treat anxiety disorder. Treating behavioral problems with medication should only be done along with a careful analysis of the behavioral issue and a comprehensive plan to target those issues. With that being said, the most common reason to start medications are to prevent changes in level of care, such as hospitalization or changing in a classroom setting. So if the individual gains the most out of their environment, medication may be helpful. They are more sensitive to the effects of medication, both positive and negative, so start low and go slow. If using psychotropics with patients, remember, do the same as you would in all child psychiatry, except start low and go slow. I can't repeat this enough. They are susceptible to the effects of medication, both positive and negative, even those listed as rare on the package inserts, such as enuresis for some of the from antipsychotics. The fewest possible medications with the lowest doses that are effective. Because individuals with IDD may have more medical comorbidities, keep in mind your drug-drug interactions and side effects. If ADHD symptoms are present, use stimulants as the first-line agent, just as in children without IDD. As noted before, there's little research on children with IDD, as it's mostly an exclusion criteria for many of our pharmacological research studies. They are more susceptible to side effects. There's little research and actually no studies of SSRIs in individuals with IDD without co-occurring autism spectrum disorders. There are very few studies on tricyclics, which showed worsening behavior. Benzodiazepines can worsen symptoms and have negative effects on cognition, so there's little evidence. Buspirone has had some uncontrolled studies with mixed results. And beta blockers actually have little evidence, with one open-label trial with some reduction in aggression and self-injurious behavior. There's few studies in bipolar disorder and IDD. Lithium was shown efficacious in a few studies for aggression, but had incredibly significant side effects. And valproate has no studies in IDD in the absence of ASD. Antipsychotics are the most commonly prescribed psychotropic for patients with IDD. Target symptoms are broad, including psychotic symptoms, behavioral issues, self-injurious behavior, severe stereotypies, hyperactivity, and severe temper tantrums. There's good evidence for risperidone in children with IDD and irritability. Interestingly, there is not good evidence for adults with IDD and psychotropics. The key to antipsychotics in practice is basically avoid them if you can. You may be able to get the same effects from an alpha agonist or other medication without giving the side effects of weight gain and blood sugar problems. If you're using an antipsychotic medication, use the guidelines set forth in the ACAP practice parameter, getting regular weight, waist circumference, cholesterol, and blood sugar monitoring. Monitor for gynecomastia. It is difficult in a pubescent age where there is some glandular tissue that forms, and so that can be tricky. And if very young, please warn families about the prolonged use and the risk of osteopenia. Assessing side effects for all psychotropics in children with IDD is very difficult. Their self-report can be very poor, both due to communication issues and due to their overall lack of understanding of their body, how it works and how it feels. Careful observation needs to be taken for behavioral changes. Just more active could actually be akathisia, And agitation can be a side effect, or it can be just a communication that they're not feeling well from the medicine. Ask caregivers about changes in appetite, sleep, bowel habits. All the things that they may play off as just changing for other things could actually be due to the medication change you just made. Look for correlation between medication timings and new behaviors or symptoms that families might not quite understand based on the pharmacokinetics and dynamics of the medication. One more vignette to try to explain a little bit more about this. So Amy's a 5-year-old Caucasian female with cerebral palsy, deafness with a cochlear implant, severe intellectual developmental disorder, who has no verbalizations. Father reports the teachers at school note that her attention span is less than 30 seconds for any task that's preferred or not preferred. Teachers have difficulty engaging with her. And the father notes that teachers say she's constantly touching everything or will suddenly dart out of the room. You note in your office, Amy doesn't really play with much. She interacts with you quite well, loves the engagement, but when you're not engaging with her, readily hits you on the head and then hits herself. When her father responds immediately to these behaviors, stating not to do that, she laughs and smiles and giggles and is happy as can be. So, you might want to pause here and discuss this case a little bit more closely. The diagnoses in this case, ADHD, she's hyperactive, inattentive, and impulsive in at least 2 settings. Does she have autism spectrum disorder? No. She has great reciprocal interaction with the doctor as well as father. Are there co-occurring other diagnoses? It's hard to tell. She's so hyperactive. That's predominantly at the moment, but you should be aware of that as you look. Is self-injury a separate diagnosis here? Based on this information, I'd say at this time, no, because there's a single act when she doesn't get her way. And it may be more of a communication tool. It's also been reinforced by dad's attention, at least in your office setting. So, interventions. Behaviorally, helping the family understand not to reinforce this behavior and the self-injury may help a lot. Medication management for ADHD here may be helpful. Start low, go slow, and follow very closely for side effects. Be aware that sensory issues or rigidity may limit your medication choices. Be very careful in individuals with IDD and whether they need liquid medications, dissolvable medications, things that can be crushed, and be aware that you might have to call your pharmacy and find out what's available and what you can do to help the family get the kid to take the medication. People with intellectual disability, developmental disorder, are a pleasure to work with in a psychiatric practice. They deserve the correct diagnosis and a treatment that is comprehensive, that helps promote their strengths, treats all the medical and psychiatric comorbidities, and allows a person to grow to their potential. So in summary, screening all patients for intellectual developmental disorder is very important. Careful assessment and diagnosis will benefit the patient, the caregivers, and all their providers. Treatment planning involves a multidisciplinary team for all aspects of the patient's care. Pharmacotherapy, if needed, is a small but important part of the treatment plan. And if you've learned nothing else, start low and go slow. Thank you.
Hi, I'm Dr. Frampton Gwinnett, and I'm here to ask a few application questions based off that wonderful talk that we just heard. Dr. Koth, great job. Thanks so much for your talk.
Thank you very much.
Intellectual disabilities. Wanted to ask a question that I think a lot of people have in mind. A typical case, let's say a child comes into you with mild intellectual disability, and the parents, the family want to know, will this child ever be able to live independently? And what would you say?
It's a good question, and one that families often ask. If it's a young child, I usually talk about how we don't know at this point, that we can do everything possible to support the child, have them learn, and be as independent as they possibly can. But no 5-year-old with IDD or without can you really picture being independent, and so that we have to defer that. If they're older and maybe in the beginning of high school, we can start to see where their abilities are, where their strengths are, and help really use education and any social interventions we have to try to make up for those deficits so that they can hopefully be independent. The likelihood is they'll always need some help, but
Right.
the amount of scaffolding will depend very greatly on the person.
Exactly. And so you're a big proponent of IEPs. I know when a child approaches transition age and the idea, will they live independently, comes up, how do you recommend parents approach transition ages in the IEP?
It's very important that it be in the IEP. And the one caveat is not all one thing fits everyone. So it's very different. There may be a child who will be best served by a school through the age of 21 and being able to stay in a great transition program.
Yeah.
There may be a child where that doesn't fit them well,
Yeah.
and maybe they do better in a non-academic environment, learning a trade or a skill that's very different. So taking that child into consideration and not being afraid to change that IEP.
Yeah.
When you make an IEP at 12 or 14 and say, yep, they're going to stay in school there in 21, if at 16 that doesn't fit anymore, change the IEP,
Exactly.
change where they're going. But really also take into account the individual as much as what they want to do. And really build on those skills. But helping to build vocational skills early,
Right.
Their practical skills, and as well as focusing their academics around more functional skills, checkbook balancing or budgeting, maybe versus complex math.
That sounds great. So it sounds like you're recommending that our psychiatrists watching today stay very involved with the IEP process from childhood all the way through into adulthood.
Absolutely.
Okay,
it's
great.
very important.
Awesome. Our next question is involving a child with moderate intellectual disability that is noted to socialize poorly by teachers. And the question that comes up a lot is, how do you differentiate between intellectual disability and autism?
It's a great question because a child with moderate intellectual disability is going to socialize more at their cognitive age, not their chronologic age, which causes a lot of difficulty. Families will come in at times and say, but he's 16, and I'll have to say, but mentally, he's around 6 or 7.
Right.
So we need to be able to think about them acting and socializing at that age. So very differently. If they're socially appropriate at that chronologic age, or I'm sorry, at that cognitive age, then there's no reason to look at autism spectrum disorder because they're interacting at an appropriate age for that. The other thing to look for is repetitive behaviors or restricted areas of interest. Most children with IDD, while they have the things that they love, don't have those repetitive and restrictive behaviors that you see in autism spectrum disorder.
Okay. And Dr. Koth, you mentioned in your talk that patients with intellectual disability often have behavioral issues and challenges. And wanted to ask, when a patient comes in with those challenges, what medications do you consider first?
The most important thing is to remember that medication is a very small part of looking at what a behavioral problem is. It's important first to rule out all medical comorbidities. Right. So looking at things that the kid may not be able to tell you about, headaches, bowel problems, infections, all kinds of things. So ruling all of those out first is the most important step, I feel. Then get a better understanding of what the behavior is, what happens before the behavior, what happens after the behavior. What time of day does that behavior occur in? Does it occur in one or more than one setting or only one setting? What is the reaction of the people around when that behavior happens? In other words, is it reinforced and brought out? And then how or what have they done to try to intervene? Or what have they applied to first? Those are the things to first do when you have a behavior so that you can better understand what that behavior is. A lot of behaviors are forms of communication, and so addressing it with a medication wouldn't necessarily be appropriate. It would either be teaching them a more adaptive communication skill or working to have that not be an effective communication skill.
So we don't want to necessarily jump right to medications.
No.
Okay.
Set realistic expectations as well. Sometimes the behavior may be cognitively appropriate for that age.
Yeah.
Even though it might not be for chronologic. So make sure you're also applying cognitively age-appropriate behavior expectations as well. And set a plan to help all of that before you consider medication. In that, If there's comorbid psychiatric illness, absolutely you can apply medication for those purposes. Certainly if the behavior is dangerous or causing damage, that you may think about medication quickly while you do the rest of that workup or try to work on other things. But remember, start very low, go very slow, and monitor very closely for side effects.
Exactly. And you mentioned, I thought this was really important in your talk, how patients with intellectual disability might not be able to verbalize those side effects. So that's a really key component, right?
Absolutely.
Yeah.
Very key.
Excellent. Well, thanks for watching today. Dr. Koth, thank you so much. Great talk.
Thank you very much.